Welcome to the lecture for Abnormal Psychology. Today we'll be talking about physical disorders in health psychology. So about the intersection between psychology, abnormal behavior, and physical disorders. We'll talk a little about behavioral medicine. We'll focus on the impact of stress on physical health. We'll look at some examples of specific physical disorders and their relationship to psychological factors. And then we'll talk a little bit about psychosocial treatments aimed at physical problems. Okay, behavioral medicine. What is it? Well, it's an interdisciplinary approach, an interdisciplinary application of behavioral science or of psychology to the prevention, diagnosis, and treatment of medical problems. So when we say interdisciplinary, who are we talking about? Well, psychologists, counselors, social workers, physicians, and when we say physicians, we're talking about multiple specialties of physicians, and also other researchers, genetic researchers, geneticists, a wide variety of people contribute their skills and knowledge to the field of behavioral medicine, right? To trying to apply what we've learned from behavioral science, from psychology, to dealing with medical problems. A subfield of that would be health psychology. And health psychology doesn't tend to be quite as interdisciplinary. It tends to be mostly psychologists, maybe some counselors. And these are, so there aren't usually doctors doing health psychology. They may be involved in behavioral medicine, but that interdisciplinary team working in a behavioral medicine capacity, the people from the field of psychology will probably come from a field that's focused on health psychology, right? Which is where you study the psychological factors that affect physical health. Okay. So the two primary areas of focus for health psychology, which is kind of the component of behavioral medicine we're most interested in, are going to be how psychosocial factors influence biological processes, right? So again, that kind of mind-body dualism that's been debated for hundreds of years, looking at how the actual biological physical processes, gene expression, hormone release, regulation of systems can be influenced by thoughts and feelings and behaviors, right? That it doesn't just go, it's not this one direction relationship where you think, okay, well, if you have this surge of hormones, that's going to change how you're experiencing this emotion. That's going to change how you feel. Yeah, it does happen that way, where biological processes can impact psychological processes, but we also know it happens in reverse as well. And that's one of the major areas we focus on in health psychology. Another one would be looking at how behavioral patterns increase the risk for injury, infection, or disease. So these are those things talking about engaging in risky behaviors, things that are going to put you in danger of getting hurt or getting sick. And then on the flip side of that, from more of a positive psychology point of view, what are the behavioral patterns that can be established that might make people less likely to become unwell? Okay. In terms of becoming unwell from psychological factors, we know stress is the major culprit. And a typical stress response, it kind of has three stages, right? It starts with alarm, where you have this sympathetic arousal, right? So something's wrong. And this is an adaptive thing, right? Where your body needs to start just to get ready to deal with some problem, something that's going on in the environment. And then if the stressor, the thing that's causing stress, persists, you may move to phase two, which is resistance. So here's where you can keeping kind of energy level up and hyper arousal. So you're mobilizing, you're coping, and figuring out what action you're going to take to deal with this. So, oh, something's wrong. Still wrong. All right, let's get something done. Let's fix this. But then eventually, you may move to exhaustion, which think back to we talked about depression. If you're like, okay, let's get ready to do something about this, and you find you can't do something, you have this kind of learned helplessness. Well, then that may lead to where you have this chronic stress where the stressor is always there. You're not able to deal with it. You're not able to remove the impending problem, and always have this problem hanging over you like the sword of Damocles, that eventually that's going to lead to some potentially permanent biological damage, right? So again, stress is kind of adaptive at the first stage, second stage, the third stage. If you can't do something about it, it begins to destroy you. In terms of how it happens, right? The physiology of stress, as we said, it starts off with activation of the sympathetic branch of the autonomic nervous system. It involves the release and communication among stress hormones. You've got these neuropeptides, neuromodulators going throughout the body from different glands communicating with each other, and those glands are typically getting their messages from the central nervous system, the brain sending messages, to the pituitary, the master gland, to communicate to other glands, and then feedback coming back up from those hormones to the brain. So it's this kind of circuit that most of the focus in this area is looking at not so much the neurotransmitters in the brain, but the stress hormones that are in the blood and the circulatory system. That those messengers seem to be the ones that we're most interested in terms of the interface between the psychological and the biological. As we've talked about before, the hypothalamic pituitary adrenocortical axis, HPA, is going to be big here. And this is where you've got the hypothalamus tract going down the pituitary to the adrenal glands on the kidneys, and that communication back and forth, up and down, is super important in the stress response, right? And again, at some points it's adaptive, at some points it becomes destructive. And when it's becoming destructive from a physiological point of view, it usually has to do with cell death in the hippocampus, right? Because the hippocampus in this this system involving kind of the endocrine system and the limbic system in the brain largely, the hippocampus's job is typically to turn off the stress response. So there's alarm, resistance, okay, we dealt with it, hippocampus drawing from our kind of memory stores, we've learned our lesson, good, stressors dealt with, shut it down. Well, if it doesn't get shut down, unfortunately one thing that happens is the chronic stress, those hormones, particular cortisol, leads to death of cells in the hippocampus, which means that the off switch for stress gets broken. And when the off switch for stress gets broken, what do you get? Well, you get more stress, you get chronic stress. And as we saw in earlier chapters, that may lead to things like depression, and then it can also manifest in a variety of other ways, impacting not just psychological health, but also physical health. Okay, so then all these things, stress requires a stressor, something that's causing problems, some threat in the environment. And just because there's a stressor present doesn't mean you're necessarily going to experience stress or the same amount of stress as somebody else given the same stressor. So what influences the degree to which something is stressful? Well, one component, like most things, is going to be genetic vulnerability, right? People have greater or lesser vulnerability to experience stress in response to stressors. And there's also this interesting research looking at social dominance in baboons, right? Sapolsky finding that these kind of baboons that are dominant in this kind of very hierarchical society tended to experience less stress in a biological sense, right? They had lower resting cortisol levels, and when a stressor came, their cortisol spiked more quickly, so they had a kind of a bigger alarm resistance. I'm going to deal with this reaction than those who are lower down on the hierarchy. And this seems to be because, at least in these primates that were studied, having that social dominance led to greater control and predictability, right? So they can, when something happens, because they're high up on the food chain and that social hierarchy, they can deal with it. And because they believe they can deal with it, and they know, okay, if I do this, that's going to solve that problem. I can make this person go over there. I can make that person go over there, that they experience less stress. So the same kind of thing we see in humans, not necessarily with a social dominance, but in terms of what's attendant to social dominance, and that's that control and predictability, which we often think of in terms of self-efficacy. So there's a degree to which you believe that you can affect change in your world. And that idea of self-efficacy seems to be really important in predicting stress responses. So two people both, they get a note from their boss saying, hey, something I want to talk to you about, come into my office at the end of the day. Somebody with higher self-efficacy might say, okay, well, I guess they've got a problem, but I'm sure I can handle it, I'll solve it. They're not going to experience a great deal of stress. Maybe some, not nearly as much as somebody else who has much lower self-efficacy, who thinks, oh, they've got a problem and I'm not going to deal with it, I'm going to look foolish, and then they're going to yell at me and I'll probably get fired. Well, now that person is going to experience much more stress. So this self-efficacy, this kind of cognitive schema that's built over time, seems to be super important in terms of stress response. notably for those of you who want to go into the counseling field, this is something that you can target. You can build up people's sense of self-efficacy. You can challenge negative beliefs they have about their efficacy within reason, right? And there are some actual limits where there are differences in our society, kind of like the baboons that Sapolsky studied. Some people have more power, more agency than others, right? Some of that comes with economic status, some of it comes with age, some of it comes with education, where some people have more options open to them. And it's important to be aware of that kind of social, cultural piece, and not tell people, well, just suck it up and fix it. Well, they may not be in a position where they have quite as many options as somebody else. So being sensitive to that, and also realizing the importance of advocating for people to have a greater sense of agency in their life, regardless of their station. Okay, so looking at stress on a continuum in terms of the self-efficacy and the sense of control. So if you have this kind of high self-efficacy and you think, okay, yep, I got this, I can cope, then when a stressor comes, you might be excited. Oh, a problem? Sweet. I'm going to have a chance to prove myself. This is going to be challenging. It's going to be stimulating. It feels good, right? Somebody else who has less self-efficacy, oh, this is going to be a challenge. I'm not sure if I can deal with this. Might be some stress. I think I can, but maybe, I don't know. Oh, it's a little stressful. If you get a little more doubtful, I really don't think I can. This is going to be bad. Now I'm worried about it. That cognitive component of anxiety comes in. We start moving from excitement to stress down to anxiety, the less sense of control you have. And then when you have really that loss of control, there's really nothing I can do about it. It's hopeless, right? And when we talk about hopelessness, depression. So again, that same sort of thing where there's some stressor, how somebody reacts on this kind of continuum from depression to excitement may really be influenced by the degree to which they believe they can cope with what life throws at them. Again, bringing back kind of the importance of those schemas, those kind of cognitive styles of interacting with the world. The impact of stress on the immune system functioning. We know there's a relationship because, for one thing, we know that immune response can be conditioned, right? It can be learned, which is really interesting. Studies with rats where you give them drugs that will suppress their immune system, and you pair it with sugar water. And you can give them the sugar water with the drug that suppresses the immune system, and you measure T cell count go down. Do that over time, where you're pairing sugar water with the drug, and then eventually you just give them sugar water, and their immune system suppresses, right? Because they've learned that association. So if they can learn that association, what other associations can we learn, right? So to what degree can experiences impact immune functioning? It seems to be a great deal. And one way that it happens is from the hormonal stress response, right? Whenever you're stressed and you have all these hormones going throughout your body, communicating with different glands, one thing that it does, kind of this cascade of reactions, is lead to this chronic inflammation. And inflammation typically being an autoimmune response, right? Where we're going to feel redness around a wound. That means, okay, you've got an infection in your body trying to fight. You got your macrophages and stuff attacking bacterial or viral infections, right? But stress can cause those processes to kick off when there's not something invading your body, which can then lead your autoimmune system to attack itself, right? It can also lead it to kind of have a heightened immune response. It can also go the other way, shift down, where you have a depressed immune response. And there's lots of studies looking at that where we can show tracking people over time for long periods of time, big groups. People that are experiencing higher levels of stress are going to get more illnesses, even things like the common cold. You're more susceptible to getting a cold if you're in a chronic stress than if you don't have that kind of chronic stress. And again, it's not like short little bits of stress. Oh, I was really stressed yesterday, but now I'm fine. Okay, that's probably not going to impact your immune system. It's more about the long-term, day after day, these things building. Because again, the process, it's this cascade process, often involving gene expression, which takes time. So exposing yourself to challenge, to something that could be stressful, isn't necessarily bad. It's not going to make you sick, but spending months or years in a stressful situation and not doing anything about it, now, yeah, that is going to cause damage. It's going to cause impaired immune functioning, putting you at risk for a lot of health problems. So looking at some health problems that are involved. Obviously, we're talking about suppressing immune function. HIV/AIDS is going to be important. So one thing we know is that stress reduction programs, where you have people that have identified that have HIV, maybe even AIDS, which is kind of one possible outcome of having the HIV infection. If you enroll people in these kind of comprehensive stress reduction programs, you can slow down the progression of the disease, right? So you can't cure AIDS by taking away stress, but you certainly can slow it down, because when you have this kind of autoimmune deficiency syndrome where your immune system is slowly shutting down. If you decrease stress, you can slow that progress, maybe even arrest it, give yourself a fighting chance. And we also know that reducing stress improves immune system functioning in general. So that would seem to be a good thing. In terms of health psychology and behavioral science, we also were looking at HIV/AIDS in terms of prevention of acquiring the disease, spreading the disease. There's a role for psychology here in terms of helping people reduce risky behaviors. So that has to do with unprotected sex, sharing needles, which all has to do a lot with psychoeducation, motivation, ignorance, fear, all those things. Psychology has a role in this field to help shape behavior, right? Because if you think back to, if you took intro psych, hopefully at some point in time, they talked about the purpose of psychological science and behavioral science, right? And they talked about DUPC, D-U-P-C, to describe, understand, predict, and control. When we say control, it's not like you're a big brother overlord trying to control your behavior, but we do want to understand behavior enough that we can control it. We can influence people's behavior. In this case, influence people's behavior to make wiser decisions to keep themselves healthier, and then keep the population healthier too, in terms of preventing spread of disease. Looking at cancer. One of the big focal points here is on coping responses. People that have a greater sense of control over their, not just their disease and their treatment, but their life, tend to have better outcomes when it comes to cancer. And again, you're not going to find a psychological cure for cancer, but you certainly can, and we do see people living longer that are getting psychosocial treatments that are diagnosed with cancer. And part of it has to do with increasing their sense of control, decreasing the sense of helplessness and the depression that comes with it, and also increasing their coping resources. So yeah, you're not going to stop them from having stress, but if you can teach them how to deal with it, okay, when you do have stress, when you go in for that checkup and your numbers are down, how are you going to cope with it? How are you going to deal? If you cope with it one way, okay, maybe your numbers will level off. Maybe they'll bump up a little bit. If you don't cope with it or you cope poorly, then those numbers may go further down than they would have if you had any coping resources. We also know that supportive relationships tend to buffer stress. So people diagnosed with cancer tend to have better outcomes if they have more supportive relationships. So that's another area that psychology and counseling can kind of have an influence to help people build those relationships, and not just in terms of telling people, hey, relationships are important, be nice to people, but in terms of like family therapy, systemic therapies, where you're involving other people in dealing with their fear of getting close to someone who's been diagnosed with an illness that may be terminal, right? Well, I don't want to talk to them because it'll just make it that much sadder when they die. They're not dead yet, right? And dealing with those issues, those kind of systemic issues, can be important and can improve the quality of life. And again, potentially give the person a fighting chance to beat cancer. Now, one of the ones we talk the most about are cardiovascular problems, right? Heart disease. With one of the big ones being hypertension, high blood pressure. And lots of different studies about this. But the two things that seem to stand out in terms of characteristics that are predictive of hypertension, well, psychological influence of hypertension, because obviously we know there are some genetic influences, there are dietary influences in terms of your salt intake. But in terms of psychological factors, it's about hostility and impatience. So people that are angry and people that have this kind of time urgency, I need this done now. Those folks are going to be more likely to struggle with hypertension, which again puts them at risk for things like stroke. Learning to deal with those things might be important. Coronary heart disease, like heart attacks. There's been lots of talk for years about kind of type A and type B personalities, where your type A are these kind of hard driving, got to do it my way. Some of that hostility and patience in there as well, but also usually very high achieving, focused. You think about business people, corporate types being type A versus type B, meaning kind of artsy, fartsy, artistic folks. Like, yeah, what happens, it's cool. The evidence on this is mixed, right? And partly because it's really hard to put people into camps of type A versus type B, right? There's two types of people in the world. The type that think you can put people in two types, and then the people that don't think so. What does that mean? So generally, kind of trying to have this dichotomous typology isn't that effective. But if we look at, okay, well, what do we mean by type A? We look at the characteristics. There are certain things that stand out. And what seems to be is it's about negative emotions and the chronic experience of negative emotions, primarily anger, but also for some folks, depression and anxiety. So these are things that are going to put people at greater risk for heart disease. Because again, anger isn't just in your head. It starts in your head and then it goes down to your body. When you're angry, it causes changes in your blood pressure and your heart rate, hormonal release, which again, getting angry once in a while isn't bad. It's probably healthy, and it's healthy to express your anger in appropriate ways. But being chronically angry, repeatedly revving the engine of the body to the high levels involved in anger seems to be damaging over time to the heart. Chronic pain. This is one of the trickiest things to deal with from a psychological perspective, from a medical perspective. In terms of psychological aspects that influence the experience of chronic pain, and again, a quick distinction. Acute pain, it hurts right now and then it goes away. Chronic pain, it may not hurt as much as acute pain, but it always hurts, right? Just maybe pain begins as acute and just doesn't go away, just sticks around. That's that chronic pain. In terms of why does it stick around? Again, we come back to that perceived control. That seems to play a role. People that feel kind of helpless tend to be more likely to experience chronic pain. Negative emotion, which again, this is one of those kind of chicken and the egg type correlational things that, okay, are you always kind of angry, sad, anxious because you're in pain? Or is your pain being exacerbated, worsened by the fact that you're always angry, depressed, and anxious? And it seems to be a little bit of both, a bit of a reciprocal relationship there. And then thirdly, for some folks, there's some social reinforcement to the pain, right? Where people maybe are kind of shitty to you at one point in time, and then you have an injury and you're hurt, and then they're nicer to you. Well, there's some reinforcement of that. Well, wow, they're nice to me when I hurt. Maybe I should hurt more. And again, it's probably not a conscious decision, right? Because again, we're obviously not lab rats and pigeons, but we act like it sometimes. We are susceptible to classical conditioning, to operant conditioning. And so things that are rewarding are more likely to be repeated. So if I talk about it hurting and somebody says, oh, you poor thing, I'm more likely to talk about it hurting. And the more I talk about it, the more I might believe it, and you get into that loop. And again, usually not by itself, but that can kind of be one component. That can explain some portion of the variability in chronic pain response. But again, seldom to never is pain 100% psychological. There's almost always some biological component as well. In terms of the biological components, we talk about the fact that in the body there are endogenous opioids, right? So there are substances in your body that will attach to neurotransmitter receptors in your brain and in other parts of the nervous system, and you feel the absence of pain. shuts down the pain response, right? And that's what your opiates like heroin, oxycodone, those take advantage of. They either mimic those endogenous opioids, or they increase the binding of those opioids to stop the pain messages. Right? And again, that's something that your body has naturally built, where you cut your finger, ow, that hurts, so that you stop cutting your finger. But it doesn't do any good once you see the finger, it hurts, and you do something about it to keep hurting forever. So there has to be this off switch. And the off switch comes in the form of these opioids, where they say, okay, we're good, stop it. And one thing that seems to control them are different nerve fibers. And according to the gate control theory of pain, you've got these large fibers and small fibers. And we won't get too much into the details, but basically, if you think about you've got pain receptors externally, throughout your body, not in your brain, right? That's why when you see people, if you ever see them do brain surgery, where they pop the top and they're poking around somebody's brain, you don't anesthetize the brain. There's no pain receptors there. The pain receptors are elsewhere. So the pain receptors are elsewhere in the body, like in your hands and feet, extremities, right? Elsewhere in your body. And they send messages up to the brain. And the brain sends messages back down. And you have this back and forth relationship where, the message is going up saying, ow, this hurts. Your brain's like, wow, yeah, that hurts. And sometimes, you bring in other input that says, yeah, that hurts, but can't really deal with that right now. Gotta keep doing this. You're running a marathon, it hurts. Yeah, but I'm winning. Don't think about the pain. Keep moving. I'm focusing on the winning. I'm focusing on this, right? Or you're having a great time doing something. Well, this is really enjoyable. It kind of hurts, but I'm having such a good time. And your brain will shut down the pain messages, right? Where the thing causing the pain at the stimulus site is still causing the pain, but the message isn't getting to the brain, so you don't feel it, right? Other times, the brain says, oh, that hurts a little. Oh, but this seems really dangerous, and we should probably get out of here. Yeah, I'm going to crank up the volume on that sound. Yep, still hurts. Get out of here. Get out. You haven't left. I'm going to keep turning it up, right? So the brain can kind of shut down pain, or it can amplify pain. And with chronic pain, there seems to be a broken gate, right, where the brain isn't able to send those messages down. And this is where we go back to that experience of negative emotion, where typically the brain would say, okay, that's enough. Turn off the pain signal now. That message gets disrupted, gets intercepted by interference from negative emotion and kind of the physiological manifestation of negative emotion in the limbic system, right? So you've got this static in the signal where it shouldn't hurt anymore, but it still does. And you get that with chronic pain. You also see it, interestingly, with things like phantom limb pain. People that have lost a limb, an arm, or a leg, and they still hurt, right? Because the pain signal, the receptor site in the brain is going, ow, 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 and they're not able to get the message that says, oh, it's good now, you're fine. Which is interesting if you think about little kids, if they fall and hurt themselves, sometimes you tell them, okay, look at your hand, it's fine. And if they look at their hand, oh, okay, it's fine, and they stop crying. Again, because they need to have that message sent back that, yes, it is fine. I can turn off the things that are amplifying the pain signal. But pain notoriously difficult to treat. It's one of the reasons why we have the opioid epidemic in America right now, killing lots of people. It often starts with pain and then trying to treat it with medications that are good at making pain stop for a little while, but not great at long-term, not great at chronic pain. Another tricky thing is chronic fatigue syndrome, right? Typified by a lack of energy, marked fatigue, pain, again, and even possibly a low-grade fever. So this is one of those areas in the field of behavioral medicine that tend to be a bit controversial. Because you wonder, well, okay, is this chronic fatigue syndrome is maybe caused by some virus or some other pathogen that we just haven't identified yet, right? They haven't found it. And for most things, measles, mumps, rubella, those things we can identify. Okay, here's a little bug that's causing these symptoms. For chronic fatigue syndrome, they haven't been able to find it. And when you can't find something that should be there, you don't know if, well, it's because nothing's there and it's something else, or you just haven't found it yet. So might it be a virus? Could be. Might it be psychosomatic in terms of there's no pathogen causing the symptoms? It's more of stress and anxiety causing the fatigue, where you just are kind of depressed, and that's causing the symptoms? Or might it be both, right? That's kind of one theory, is that there may be some period of acute illness that has some fatigue, and people that are kind of almost type A, where they tend to be go, they see that and they go, oh wow, my body's acting weird and I'm real tired all the time, and then that freaks them out. And then even whenever the disease process has resolved, they begin focusing, ruminating on the disease and the low energy, and then they've been on their back for a while, and so they've had some muscle atrophy and they're a little out of shape, and rather than go, wow, I'm out of shape, time to get back in shape, they go, oh yeah, I'm out of shape because I have this weird disease that's causing me to be tired all the time, and now I'm kind of hopeless and can't do anything about it. Could it be that? Maybe. Could it just be a virus? Yeah, maybe. We really don't know. It's really one of those things that's still one of the mysteries in behavioral medicine. Okay, in terms of treatments of physical disorders using a psychosocial approach, which is typically done in conjunction with, obviously, a medical approach. If somebody has cancer, you would say, you know what you got to start with? You got to talk to somebody, have some therapy. Yeah, but also probably chemo and radiation would be good too, maybe surgery. So usually these things are in combination with medical interventions as well. One thing that people find helpful for a variety of things, biofeedback. Right? This is where you learn to control your bodily responses. You hook people up to sensors, heart rate, galvanic skin response, maybe even your kind of face muscles, EMG, where you can teach people basically that they can control things that don't seem controllable, right? Like you can speed your heart rate up, you can slow your heart rate down, you can even raise and lower your blood pressure, right? Which you wouldn't think, can you really do that? Yeah. And it's much easier for a lot of people to at first raise those things than it is to lower them. But once you learn you can raise it, once you can learn to make yourself, I can make myself more physiologically stressed. If I can go up, surely I can go down. When they can learn that control, that's something that can be helpful with chronic headaches and hypertension, right? And again, it seems to be not so much about the biological process. Well, okay, well, we're relaxing these muscles, and now you've lost the tension, so you're fine. It has to do really with the cognitive component of gaining a sense of control. So, okay, the cells and the systems may be working the same way, but now I feel more in control about it. If I feel more control about it, my symptoms seem to be experienced as better. Another approach would be, a variety of approaches here, relaxation and meditation. One approach to relaxation is progressive muscle relaxation. This is particularly effective with people that have physical ailments that involve kind of chronic muscle tension. So it's also something we see used with generalized anxiety disorder. And this is where you are walking people through progressively tightening and then relaxing different muscle groups, right? So you use that therapy voice. You go, all right, now I want you to imagine you're tensing your hands, making a fist, holding it tight, focusing on the tightness in your hand. Feel that tension. And then let it go with your hand opening as the tension melts out of your hand, feeling warm and tingly. Right, so you go through that, through all the different, through the body, either head to toe or toe to head, either way, but progressively from one area to the next, having people tighten and then relax muscles. Begin to teach them usually that, okay, it helps them realize where they have muscle tension, and then kind of paradoxically, purposely tightening something and then letting go of that tension can help loosen up muscles that are chronically tense, and that tends to help with stress, as does different types of meditation, transcendental being one flavor of meditation, which is really a lot about being in the moment, trying to get out of your head by just focusing on something as simple as your breathing. Don't think of anything else. If you do, that's okay. Don't judge. Just breathe. It's some real interesting studies coming out here lately with this stuff where we're seeing some observable changes in brain structure and physiology for long-term practitioners of transcendental meditation. So again, like a lot of other things with stress, psychology in the body, there are no quick fixes, right? So a little bit of stress right now isn't going to hurt you that bad. A little bit of meditation right now isn't going to help you that much. It's about making these long-term commitments to choices of healthier living to reduce stress that seem to have an impact, right? So it's cumulative. We also talk a little bit about prevention in behavioral science, and 3 different types of prevention. Primary is when you're trying to prevent disease or injuries before they occur. So this is about a lot of psychoeducation about the risks of particular diseases. Think about sexually transmitted diseases, diseases transmitted through drug use, educating people about how to safely engage in those behaviors to reduce the likelihood of contracting disease. Anti-smoking campaigns that are aimed at stopping people from ever starting to smoke, right, which we know causes cancer. Trying to prevent lung cancer by having these education anti-tobacco campaigns. That's primary, so it's trying to keep it from happening. Secondary, okay, people that already have the disease, it's already occurred, we're trying to reduce the impact of it. A lot of this has to do with early detection, so having scheduling, your mammograms, prostate exams, to where, okay, when we have those exams, they don't keep you from getting breast cancer, colon cancer, prostate cancer, but if we identify it early, then we can begin treatment, and you're much more likely to have a better outcome, less likely to die. So primary, before you get sick. Secondary, trying to catch things as soon as possible, reduce the impact. And then tertiary is, again, where we're looking at managing chronic disease. So somebody has a disease, it's developed, it's established, and this is the most costly in terms of resources and times type of preventive intervention, where we're basically trying to prevent you from dying, right? So somebody that has a chronic illness, that has lupus, teaching them ways of dealing with stress to keep their immune system as healthy as possible, to live as long as possible, to keep from getting exposed to other diseases. Okay, take home. Stress can kill you. Seriously. It can definitely make you sick, and it's not just a saying, oh yeah, the stress, it'll kill you. No, it really will. It's one of the biggest contributors to mortality, morbidity in the developed world. Right? So take it easy. So I mean, don't worry about stress killing you, because that will actually kill you, ironically. So try not to worry about it. No, again, it's not about trying not to worry, trying not to be stressed. Be proactive in terms of coping with stress, because you can't prevent stressors from coming into your life. That's an inevitable part of being human. But you can deal with how you're going to react to them. And that has to do with working on the way you think about control, right? What do you tell yourself about your ability to handle things? If you tell yourself you can't handle it, then you're going to be less likely to handle it. If you tell yourself you can handle it, well, that's going to improve your odds, right? And you don't want to be Pollyannish. I can do anything. No, but I can take reasonable steps to accomplish this, to make this better. Yeah, that's not crazy. And that's helpful to think that way. And it's particularly harmful in terms of stress to think the other way. The experience of negative emotions, which again, emotions are signals. They're important signals about things in our life. And if you pay attention to the signals and change your life, so when you get angry, okay, go do something about the thing that made you angry, and you'll no longer be angry. If you're sad, go do something about the thing that made you sad, and you'll no longer be sad. If you stay in situations that are maladaptive, that are going to cause you to chronically experience negative emotions, it's going to take a toll physically. The other thing we know to kind of buffer the impact of stress is social support, having people around you that care about you and that you care about, and that you can, again, kind of process these negative emotions with. That is important. Don't take it for granted. In terms of big picture behavioral medicine, there are multiple points of intervention, right? We talk about the kind of primary, secondary, tertiary prevention, and also what we can do in terms of helping people that have illnesses, in terms of decreasing stress, increasing social connection, changing the way they think about the control over their life, the control over their illness or their treatment, So if this is an area you're interested in, there are lots of opportunities starting here as kind of undergrad psychology major to enter the field of behavioral medicine, either as a psychologist, as a physician, or one of the other many fields that are involved in kind of this multidisciplinary approach, examining this juncture of the psychological and the biological. And along those lines, the last point is to remember this is a reciprocal relation between psychology and biology. So we focus a lot about how the psychology impacts the biology, but it goes both ways, right? When you are physically sick, it's harder to experience positive emotions, right? And being diagnosed with a major illness, can be an incredible shock, right? And that shock, people often talk about denial. Well, denial is a bad thing. Well, long term, yeah. Short term might be good, because too much of a big shock physiologically can be damaging to your heart, to your immune system, right? So denial kind of gives your body some time to slowly ramp up in the background. It's going, did I really hear what I thought I heard? Versus it hitting you all at once. So again, the psychological affects the biological, and the biological affects the psychological, all in one big cycle. That's all for now. Take care.